Okay, let's get started. Welcome back to class, and we're going to take a look today at the muscles of the human body. The good news is that there's only 60 muscles to look at, as opposed to 206 bones and 200 plus foramens and fossas and grooves and processes from the bones. And a lot of what you hear today involving the muscles, you're going to be able to identify them with the bones that they attach to. So that'll make it a lot, I'd like to think it'll make it a lot easier for you in this. So anyway, let's go ahead. Well, first of all, does anybody have any questions about anything? Okay, then I'm going to go ahead and get into this. And so you should all see the slide that says muscles, origins, insertions, and actions. I sent you a list of all the terms that would be associated with the muscle test. The list of all the muscles, the list of all their actions, the list of their insertions and their origins. Those are the key terms. I'm going to go over them today. And I'm going to try to emphasize which ones are more important than others, because you're not going to have to tell me or anybody, the origin, insertion, and action of every muscle in the body. And that's not what we're about today. So if you want another list of the muscles, if you go into the table of contents for this class, listed under content, obviously, you'll see, I think the second or third, probably the third listing down is the study guide. And the study guide has had all the list of all the bones, and now it has a list of all the muscles, their origins, and origins, insertions, and actions. So we're not going to go over all 60 of those muscles with all of their origins, insertions, and actions. We're going to go over all 60 muscles, but only a handful are going to have the origin, insertion, and action. So, and I'm tired of saying that, so I'm going to go on to new stuff here, a new slide. Okay. So, how do we attach muscles to bone? We know that muscles attach to bone through tendons. Muscles don't pull on bones directly. Muscles pull on tendons, and tendons pull on bones. And we know that there is what we call an origin and an insertion. The origin is where we are attached to a bone that doesn't move. The origin of every muscle is a bone that doesn't move. So it has to, the muscle has to have something to pull again, to anchor to. It anchors to that structure. So the origin of a muscle is its attachment to an immovable bone, like the skull, for example. Bones of the skull don't, most of the bones of the skull don't move. Or the sternum doesn't move, at least not very much anyway. The insertion is the attachment of a muscle to an immovable bone. So I'm sorry, to a movable bone. So if you you're only going to have one insertion, you may have more than one origins. So origin and insertion, the bone that moves. We know that there are at least there have to be two connections, an origin and an insertion, but you can have more than one origin. And the movement is simply the muscle contracting and pulling on the bone. All muscles can do is contract. They can't do anything else. They can contract and they relax. They contract and they relax. It's all they can do is they can contract. And action is controlled by how many muscle cells in a muscle are contracting. Again, the bone that doesn't move is the origin. The bone that moves is the insertion. Now here's an example of this. This is a very large set of muscles. These are a paired set that you can see that they are connected to the sternum and the clavicle, and also to the mastoid process. Now these muscles control the movement of our head from turning left and right. They allow us to turn our head to the left or turn our head to the right, or even nod our head up and down. The origin and the insertion of these muscles are not what you think. The origin is the sternum and the clavicle. Two origins on this one. So the origin is the sternum and the clavicle. Its insertion is on the mastoid process. Mastoid process, you know, that bump that we find right behind our ear, that is very porous bone, a lot of spongy bone present there, and that this muscle is anchored to the mastoid process, and when this muscle on the left or right side contracts, you turn your head in the direction of the contracting muscle. So the mastoid process moves, the head turns. The sternum and the clavicle don't move. They stay stationary. Okay. This will become clearer as we go along, I'm sure. So here we're looking at an arm. I know it's upside down and it's not supposed to be, but this is how I haven't gotten all my slides yet. I can turn it around, but it's a lot of effort, and I'm working on it. So you'll see some that are turned around properly. Anyway, this is an arm. Now the first muscle we see here is a very simple little muscle right here in the middle, and it's called the brachial muscle, or the brachialis. And it's located between the triceps and the biceps. The triceps is on the posterior surface of the arm down here, and the biceps sits on the superior surface, or the top surface here. And the brachial is right in between. Now, a muscle that we're probably very familiar with is the biceps brachii. It's the muscle that's on the upper surface of our arm at the humerus. And it is called biceps because it has two heads. It has two origins. At the end of the biceps brachii, the end of the biceps brachii, the head end is covered by a muscle that we all know and love. It's the deltoid muscle. This is where we always get our injections. This is our shoulder muscle, if you will. So we call it deltoid because it's shaped like a delta, or the symbol delta. So covers our shoulder, covers the glenoid cavity, covers the origin of both the biceps and the triceps. There's our triceps muscle there. Triceps has three heads. It originates on three locations. And so this is we're all familiar with the biceps and triceps. We've all heard of the biceps and triceps muscles before. So these, one on the superior surface of the arm, one on the inferior surface of the arm. And then we have another muscle here that does amazing things for us. This one right here is called the brachioradialis. Brachioradialis, and you can see it originates on the humerus right here. You can see it's characterized by these three little nerves. You can see, you can always look and see, we see the three nerves. That's where the brachioradialis is. It comes down and curves around. It inserts itself at the end of the radius. And what this muscle does is this is the muscle we use to turn our forearm at the radius. It rotates our radius around the capitulum of the humerus. And this is what we use to open a doorknob. Turn a doorknob to open a door, to turn a key. This is what we use when we're using a screwdriver. And this allows us to rotate our arm, allows the head of the radius to rotate over the capitulum of the humerus. And in doing so, our arm turns around. Now, again, think about opening a door, turning a doorknob. This is the brachioradialis. There it is now. You can see its origin is up there on the humerus. And when we're talking about action and stationary and movable, yes, we know that the humerus moves, but when this muscle contracts, when the brachioradialis contracts, the radius moves and the humerus doesn't. The bone that doesn't move, can be a perfectly good movable bone for other reasons. Like we know the humerus moves, but for the contraction of the brachioradialis to turn the radius around the capitulum, to open a doorknob, to turn a screw, to put in a light bulb, brachioradialis, its origin is on the humerus. The humerus isn't moving when the brachioradialis is contracting, but the radius is. So, and we use this all the time. Now we've got it flipped over so it looks like we can see an arm, for real. There's the deltoid muscle up at the top. Again, we're all familiar with that. It covers our shoulder. It's where we get our injections, vaccinations and stuff like that. Now, there's our biceps brachii on the superior surface. There's our triceps brachii on the inferior surface. There's an interesting little muscle here called the teres major. And I put it out there for one reason, because it has the term major. When we see the term major, when we're describing a body part, particularly a muscle, if you have a major, you're going to have a minor. It's how the nomenclature, the naming of the muscles works. If we have a major, we will have a minor. There's our brachioradialis, and there is our brachialis or brachial muscle. There's two different terms for it. Either one's correct. So these are the muscles then that we encounter in the arm. We have the deltoid muscle, the biceps brachii, the triceps brachii, the brachialis, and the brachioradialis. Now there are 4 other muscles that are very, very important to us that we haven't got to yet. You're going to see those very, very shortly here. Now, how does the biceps brachii work? Let's see, got a question. Yes, it is. That, to answer your question, yes, it is to the right of the deltoid. So, okay. The biceps brachii, the muscle, superior surface of the humerus, its origin is on the scapula and on it's on the scapula and on the head of the humerus. So, but more importantly, its insertion is on the radial tuberosity. There's the radial tuberosity right there. There's the radius. There's the radial tuberosity right there. And so what the biceps brachii does, when it contracts, it causes our arm to flex at the elbow. If you were to take your arm and stick it straight out with your fingers pointed outward, and you would bend your arm so that your fingers come up and touch your shoulder, you've just flexed your arm. And the reason you can do that is because the biceps brachii has contracted and pulled on the radial tuberosity, pulling the radius backwards. And when you flex your arm, when you flex any joint, you are decreasing the angle of that particular joint. So you flex your arm, you bring your arm back, and in this case, you touch your fingers to your shoulder, and you have bent your arm. That's what the biceps brachii does. It flexes our arm at the elbow. Now, since we can't go around all day like that, we can't go around with our arm flexed, bent back like that. It'd be very awkward and uncomfortable. It looks silly. We have to straighten it out. And straightening out the arm is extension. Flexing is bending the arm, in this case, bending the arm at the elbow. Extension is extending the arm at the elbow. And how that works is now the triceps comes into play. The triceps muscle on this inferior surface of the arm inserts itself on the olecranon process on the elbow. So when your arm is flexed and you're pulling on the radial tuberosity, if we want to straighten it out, we contract the triceps and pull on the olecranon process. So if you take your arm and bring your fingers back to your shoulder, and then you want to straighten that out, your triceps muscle will contract, pull on the olecranon process, the elbow, and it'll straighten the arm out. The triceps and the biceps are an antagonistic pair. One will contract while the other relaxes. When the biceps is contracted, flexing your arm, the triceps is relaxed. When the triceps contracts and extends your arm, as we see here in this second picture, the triceps is contracted, the biceps muscle is relaxed. So in any antagonistic pair, one set of muscles is relaxed and the other is contracted. And again, that's how muscles work. They contract and they relax. That's all they can do, is they can contract and relax. And we see this on this animation here. Here we see flexing of the arm. We can see the biceps brachii here. It inserts on the radial tuberosity right here. And when this contracts, it causes the arm to flex. We decrease the angle at the elbow. Now, if we want to straighten that out and extend it, the triceps contracts and pulls on the olecranon process down here and straightens the arm out. When the triceps contracts, the biceps is relaxed. When the biceps contracts, the triceps is relaxed. So this is an antagonistic pair. Triceps and biceps, both of their origins are on the head of the humerus and the scapula. The triceps inserts on the olecranon process. The biceps inserts on the radial tuberosity. The biceps causes flexing of the arm. The triceps causes extending of the arm. And they work against each other. Okay. The deltoid muscle covers the shoulder, shaped like a delta, and it inserts itself on the deltoid tuberosity of the humerus. So we see, there's our deltoid right there. This is the deltoid here. You notice there is the deltoid tuberosity right there in the humerus. So that's its point of insertion. Of course, there's our deltoid again right there. Now we're going to get into some of the most well-known muscles of our arm and shoulder, and some that can cause a great deal of trouble. They're called the rotator cuff muscles. Now, the rotator cuff muscles are made up of 4 distinct muscles. The good news for learning what they do is they all have their origin on the scapula. All 4 of them. They all insert on the head of the humerus. And they do 2 things. They hold the head of the humerus tightly against the glenoid cavity, which is really a fossa because it's a flat area. They hold the head of the humerus tightly against the glenoid cavity, and they also give the humerus incredible flexibility in motion. That we can turn our arm around the shoulder at almost a full 360 degrees. So, first muscle that we encounter is, come on, there we go, the supraspinatus. It's located in the supraspinous fossa of the scapula. It is above the spine. It's above the spine, so it's the supraspinatus muscle in the supraspinous fossa. So, named for the fossa or flat area where it's located. Your spine is your landmark right there. Below the spine, you know, on the scapula, we've got the supraspinous fossa, the flat area below the spine. Well, here we have a muscle. There we go. Called the infraspinatus. The infraspinous fossa is the home of the infraspinatus muscle. And directly underneath the infraspinatus is the third of the four rotator cuff muscles, the teres minor. This is the minor to the teres major. It also is found on the infraspinous fossa. So we got three of the rotator cuff muscles. The teres minor is a rotator cuff muscle. The teres major is not. Make sure you know that. Make sure you star that. The teres major is not a rotator cuff muscle. It's supraspinatus, infraspinatus, teres minor, and the one you haven't seen yet is the subscapularis, which is in the subscapular fossa on the underside. This is the deltoid muscle. Rotator cuff. It forms a cuff that a socket, if you will, to hold the head of the humerus into the glenoid cavity. It allows the arm to move in all directions. It gives us great range of motion and flexibility. And these four muscles work together. We have the supraspinatus, the infraspinatus, the teres minor, and the subscapularis, located in the subscapular fossa of the scapula. And here we see the subscapularis on the underside of the scapula. So just for frame of reference, there's your biceps and your triceps. Okay, now here we can take a look at three of the four. Again, there's the spine of your scapula right here. That's your landmark. Above the spine is the supraspinatus. Remember, this picture's upside down. So there's the supraspinatus in the supraspinous fossa. There's the infraspinatus in the infraspinous fossa. There's the teres minor, also located in the infraspinous fossa. You'll notice that their origins are all on the scapula. They all these three insert on the head of the humerus. The fourth one, the subscapularis, also inserts on the head of the humerus. There's the teres minor. Now, so supraspinatus, infraspinatus, teres minor. Just because it's minor and there's a teres major doesn't mean they're connected. So, and here is our subscapularis in the subscapular fossa of the scapula. It also inserts here on the head of the humerus. So we have the subscapularis, the supraspinatus, the infraspinatus, and the teres minor. And again, we strip everything away and you can see three out of the four right there. The subscapularis muscle is not visible in here, but it would be coming around on the other side of the scapula. So here we see their actions. This is showing the subscapularis right here. It will, when it contracts, it pulls the head of the humerus forward. When the infraspinatus contracts, it pulls the head backwards, as does the teres minor. The supraspinatus pulls the head upward, raises the humerus. Now, these muscles don't operate in a vacuum, meaning they work together. You can have all four of them, you can have them pulling on the arm at the same time, causing it to move in whatever range of motion we desire. The flexibility is incredible here. Supraspinatus will pull this up, but at the same time, we may have the subscapularis pulling the arm forward. We raise our arm in a forward direction, or maybe we're pulling it backwards or whatever. But we have an incredible range of motion here. Here we see the supraspinatus pulling on the arm, and we don't see the subscapularis is more than likely pulling in this direction too, so that our arm can go out to the side. Here we see the teres minor contracting and pulling the arm laterally. Here we see the infraspinatus, again, pulling on our arm, pulling it backwards. And yet, remember, all four of these can be working together to give us this incredible range of motion. And of course, there's the subscapularis rotating the arm towards the midline in conjunction with what the other muscles are going to do, depending on what we're trying to do with our arm. And, again, I think the animation really drives home what these muscles do. They all work together. Now, problems with the rotator cuff muscles, they can get injured. We see, if we were to graph it, we would see two spikes on the graph of where the most injuries occur. Young adults and elderly. Young adults, particularly that engage in contact sports or sports with a lot of repetitive motion. You're a pitcher, for example, or some sort of repetitive motion injury, or contact sports that, or non-contact sports that suddenly become contact sports. Rotator cuff injuries occur frequently in early adulthood, young adults, depending on what kind of sports you're playing, even into the professional level, we have rotator cuff injuries. The elderly damage their rotator cuff through wear and tear. The tendons tend to get worn and they'll tear, because these are tendons that you're using constantly. They tear, they wear out. And so a common tear, a common injury is a tear of the tendon where it attaches to the humerus. It can be inflamed, it can become actually torn, and they can be surgically repaired. It's a very easy fix. Recovery time is about 6 or 8 weeks. And older people sometimes, older people have accidents. I had a friend of mine at church that tore his rotator cuff falling off of a treadmill. Yeah, it happens. And he was not an elderly person. Just I would say he's middle-aged, but the way he landed tore the tendon. Okay, so things like that happen. But a lot of older people show up with the consequences of rotator cuff injuries, and they'll need surgery to fix it. But it is a very easy fix. So this is a very common injury, a torn supraspinatus tendon, right here at the point of attachment. And this makes it painful to move the arm. And of course, how humans are. If it hurts to do something, we're not going to do it. So we have to get that fixed. And as I said, it's a very easy fix. Okay, moving on. Let's take a look at the leg now. The leg muscles. We have a number of muscles here to pay attention to, some more than others. If we take a look at our leg, the first thing we see in the lower leg is a very large muscle just to the lateral side of the anterior crest of the tibia. The anterior crest is the one that helps us to find tables and chairs in the dark by walking into them. We refer to that as our shin bone sometimes. We walk into things with it. The anterior crest, the sharp edge of the tibia, on its lateral side is this muscle called the Tibialis Anterior. Ideal name, anterior crest of the tibia, Tibialis Anterior. Tibialis Anterior has a very important role for us. The Tibialis Anterior is used to raise the toes on our foot when we walk. it does what we call dorsiflexion, elevating the front of the foot. Because when we walk, we put our heels down and then our toes come down. Because when our heels down, our toes are pointed up. So that's dorsiflexion. To put our heel down, we have to raise our toes. And the tibialis anterior does that for us. It raises our toes, it dorsiflexes our foot, it raises our foot upward as the heel goes down. So that's a very important task. Without the tibialis anterior, we can't walk because we walk, heel down, toe down, heel down, toe down, so adjacent to the tibialis anterior is the extensor digitorum longus. The extensor digitorum longus causes our toes to splay out when we step down. And we're not aware of this. Unless you walk around looking at your feet when you're walking, if your shoes are off, if you're barefoot and you watch how you're walking, you won't see it. Most of us don't do that. But the toes spread out when we step down to stabilize our position. We don't pay attention to it because we walk all the time. But the extensor digitorum longus causes our toes to spread out. And we don't fall down. At least we shouldn't. Okay, question. We have a question. Are injuries common in the extensor digitorum longus? I would imagine that, it sits right there in front. It sits directly above the metatarsals, and all sorts of things can happen with the metatarsals. I've never heard of it happening. That doesn't mean it doesn't. Just because I haven't heard of it, it would be. I would think if something happens with the metatarsals, if the metatarsals are fractured from some sort of blunt force trauma, then these muscles would get injured too. But I've never heard of anybody ever damaging just the muscles alone. It doesn't mean it can't happen. So that's best I can say. So anyway, and I would imagine if you damage those muscles, then it would be very difficult to walk. Muscles will, if muscles aren't used, they also atrophy, they shrink in size. And that's entire, if someone has their foot in a cast for a long period of time, it's possible those muscles would shrink too. And then they could become damaged. Oh, a wrestling injury. Can I ask how it happened? And did you win your match? Let me jot that down. Wrestling extensor longus. That one I want to look up and find out about that. I know you got me curious. So, okay. Now, on the posterior region of the lower leg, we have two other muscles here. We have the soleus, which is this flat muscle, which is closer, which sits right in front of the large calf muscle known as the gastrocnemius. The soleus is a flat muscle, and the gastrocnemius is what we think of as the calf muscle. And it's right, it is more posterior than the soleus is. The soleus is internal, and the gastrocnemius is external. Well, they're both external, but there's the outside muscle is the gastrocnemius. Now, the gastrocnemius inserts itself on the calcaneus Okay. Okay, so your heel bent back and your weight and great impact to my calf. Okay, then that could happen. That could happen. So I could see, yeah, I could see how that would happen. So that makes sense to me now. Okay, thank you. I am going to go look up some more information on that so we can talk about it next week. Gastrocnemius inserts, back to this now. This is another good injury location too. The gastrocnemius inserts to the calcaneus by way of the Achilles tendon. Right here, the Achilles tendon is a common site of injury because other than the rotator cuff tendons, I would think that we probably don't use any other tendon in the body as much as the Achilles tendon does, and it can get worn out. It isn't always it isn't always from contact sports. Sometimes it just tears from wear and tear. What the gastrocnemius does by way of the Achilles tendon is the gastrocnemius inserts on the calcaneus, and when it contracts, it causes it causes us to raise our heel. That's called plantar flexion, and I'll show you this in another slide here in a minute. We raise our heel. So when our heel goes up, our toes go down. Now, okay, so we take a step. We raise our foot up in the back. Our toes are down. They're spread out so we don't lose our balance. And then to take a step, we have to raise our toes. We dorsiflex, and then so our toes come up, and that's the tibialis anterior raises our toes in response to the gastrocnemius pulling our heel up. So we go heel toe, and we have what's called plantar flexion now, where we're raising up the heel. Two other muscles located here also involved with stabilizing the foot: the peroneus longus, directly in front of the soleus, and we have the peroneus brevis. And when you have a longus, you nearly always have what's known as a brevis as a descriptor. And there's probably an extensor digitorum brevis somewhere that doesn't show up on our model. Now, looking at the upper leg, we're going to repeat most of these lower leg muscles here, but looking at the upper leg, probably the largest muscle we see in our leg is the Gluteus Maximus, often referred to as the butt muscle, and other terms. Now, I've seen it called the calcaneus tendon. I've seen it called that, but we always call it the Achilles tendon. So, but it could be properly called the calcaneal tendon. But Achilles tendon is what most people call it, even in healthcare. You don't need to worry about calling it the calcaneal tendon here. Okay, now, Gluteus maximus is more than just our butt muscle. It actually has a role in moving the thigh. It is not the site of injections when we get injections in our hip, because the sciatic nerve is directly underneath the gluteus maximus. So we tend to avoid this area for injections because the risk is very high of hitting the sciatic nerve. We don't want to do that. That's painful. Another muscle here on the side of the leg, on the lateral side of the leg, is the tensor fasciae latae, a very large muscle. It comes down here all the way past the point of the knee right here. Here, of course, you get a good view of the tibialis anterior and the extensor digitorum longus there. and the peroneus longus, peroneus brevis, tibialis anterior, the soleus, and the gastrocnemius got left off of that one too. So I think it's slightly better view of the tibialis anterior here. So anyway, now let's, the gluteus maximus, as I said, very large muscle, at the top of the legs. It runs up, it's right underneath the edge of the iliac crest, for part of it anyway. And the iliac crest is a very good landmark for us because we can find the iliac crest, we can feel the iliac crest, and if we move back from the point of the crest 2 fingers width or down 2 fingers width, we find a second muscle called the gluteus medius, which is the muscle in between it. And there's also a gluteus minimus. But most of our injections are going to occur in the gluteus medius, in this area here. We want to avoid injecting anything in here simply because of the location of the sciatic nerve. The sciatic nerve is a long muscle. It's thick. It's about a long nerve, not a muscle. It's a long nerve. It's about the size of your finger and extends from the pelvis down behind our knee all the way to our great toe. And the odds are pretty good if you inject in the middle of the gluteus maximus, you can hit that nerve. So we tend to, when we get injections like antibiotics and stuff, they tend to be placed in this area over here to avoid the sciatic nerve. There's our tibialis anterior again. Now this is what I was explaining before. The dorsiflexion of the foot, raising the toes. This is what the tibialis anterior does. It dorsiflexes the foot, it raises the toes and inverts the foot so the toes are pointed up. And that's half the process of walking. Toes are pointed up, the heel is down. We'll use the Achilles tendon to raise the heel and point the toes down as we take our next step. So, and it's a very sophisticated little pattern that our foot follows as we walk. We don't pay attention to it. You know, if you try to watch your foot while you're walking, you're going to alter the whole process. Just the process of looking at it is going to alter how you walk, and more than likely you're going to fall down. So definitely don't ever try it on the stairs. So, but there's the tibialis anterior. Just to the lateral side of the anterior crest of the tibia, responsible for the dorsiflexion and inversion of our foot. Now in the upper leg, we have a cluster of 4 muscles called the quadriceps or quads. 3 of the muscles share the same first name. They're called vastus. And then there's the, we have a ringer here, and I'll show you that. These muscles are responsible for extending the leg and flexing the thigh. These are the muscles we would use when we're going to kick something, for example, or when we're going to sit down and bend our leg back. So we have the vastus medialis on the medial side of the leg. Now remember that the medial side of any leg is the big toe side. You know, legs aren't like hands. Our feet can't be flipped over like our hands can. So our thumb can be on the medial side and on the lateral side if it's palm up. We don't do that with our feet. The big toe is always on the medial side. The little toe is always on the lateral side. Vastus medialis is on the medial side. This is the ringer. This is the rectus femoris. There's the vastus lateralis on the lateral side of the leg, of the thigh. Underneath the rectus femoris is the vastus intermedius. They're all part of the quadriceps, all 4 of them. See, there is the vastus intermedius, where that hole is located, you know, a whole muscle underneath here. So we have the vastus medialis, vastus lateralis, vastus intermedius, and the rectus femoris. So these are the four quadriceps muscles. They are antagonistic to the hamstrings. The hamstrings are on the posterior surface of the leg, and their actions are the opposite of the quads. And again, since they're an antagonistic pair, when the quads contract, the hamstrings relax. When the hamstrings contract, the quads relax. So what do we see here? There is one of our four quadriceps right there. They all tend to originate on the ilium and insert on the tibial tuberosity and on the patella. That's not important. What's important is what they do. Identify the four and tell me what they do. They are going to flex the thigh and extend the lower leg. You can bend the leg at the thigh, and if you extend the lower leg, it's like you're kicking your leg out. Remember, extending is straightening it out. Flex the thigh, the opposite, and extend the lower leg. You're going to kick a ball. You're going to kick a football. You're going to kick a soccer ball. You are extending your lower leg. That's what the quadriceps muscles do for us. And their antagonists are the hamstrings. There are three of them located directly below the gluteus maximus. They have the semitendinosus, the semimembranosus, and the biceps femoris. Now, the semitendinosus sits on top of the semimembranosus. How do you remember? Well, tendinosus, think T for top. It sits directly on top of the semimembranosus. Which side is it on? Well, it's always on the medial side. So when you think semimembranosus, think M for medial. So it's the best I can do. So we have the biceps femoris on the lateral side and the semitendinosus on top of the semimembranosus on the medial side. These are the three hamstring muscles. We see them here on our model. The biceps femoris on the lateral side, the semitendinosus on the top here in the medial side, and this is a really bad model because these two are fused together. But underneath there is the semimembranosus. You can barely see it on our leg models we have. So, but these are the hamstrings. Yeah. And just like we looked at the rectus femoris, we use the biceps femoris as an example. The biceps femoris is designed, the hamstrings will extend the thigh. Remember, the quads flex the thigh. The hamstrings extend the thigh and flex the lower leg. They bend the lower leg. The quads extended the lower leg. So their actions are just the opposite. They're just the opposite of each other. When the hamstrings relax, the quads contract. When the quads contract, the hamstrings relax. So their actions are just the opposite of each other. And we see here now, the hamstrings contract, the quads relax. If the quads contract, the hamstrings relax. So this is, again, classic example of antagonistic pairs. So, okay. Now, if we look at the medial surface of the thigh, we've seen the anterior and posterior surface of the thigh. Let's look at the medial side. The lateral side doesn't have a lot to show. It just has the tensor fascia latae. But here we see probably the most unusually shaped muscle in the whole body, and that's called the sartorius. The sartorius muscle looks like a strap. If it had hooks on it, you could take it out to your truck and, use it in the cargo bed to hold things down. Because that's what it looks like. It's about the only muscle that you can take off of a model and lay it down on the table if we're doing this in class as a practical exam, and you could look at that and say, I know exactly what that is because nothing else looks like that. Because a lot of these muscles, when you take them apart, the segments are very hard to distinguish one from another. So, but the sartorius muscle is shaped like a strap. We use the sartorius muscle to stabilize our thigh when we sit cross-legged on the floor or on the ground, or at the beach, or in a big chair, or on the sofa. We sit cross-legged. We use the sartorius. We use this strap to stabilize our thigh, to allow our thigh to do that. Another muscle we use is the gracilis. The gracilis is located on the inside, on the medial side of the thigh, from the inguinal region down to the patella. It's this large flat muscle right here. It originates up by the groin and inserts down here. Again, this allows us to move our thigh, to stabilize our thigh. We have two other muscles that are located here that run underneath the gracilis and the sartorius. We have the adductor longus, which runs underneath the sartorius, and we have the adductor magnus over here, which runs underneath the gracilis and extends down here and continues underneath the sartorius. So these four muscles make up the muscle group on the medial surface of the thigh. What do they do? The gracilis is to flex the thigh and adduct the thigh. Adduct means to move the thigh in towards the midline, and flexing it allows it to move. Okay, that's what the gracilis does. It also stabilizes the thigh. Here's our sartorius. It allows the thigh to flex, and it allows the thigh to rotate. This is the one, because of its position, it allows the thigh to move so we can sit cross-legged. The adductor longus, because it's called adductor, to adduct is to bring the muscle in closer to the midline. It's like an additive effect. So there's the adductor longus. And of course, over here is the adductor magnus. Both of these are designed to adduct the thigh, to pull the thigh in towards the midline. So depending on how you're sitting, if you want to stand up or pull your legs together, standing up, sitting very formally in a chair, not have your legs spread out, where you're, like you're very relaxed and your legs are kicked out and you're taking up a lot of space, and you suddenly decide you want to get a little more formal. You pull yourself up, bring the knees close together. That's what the adductor longus and the adductor magnus do. They decrease the angle of the thigh. So lower leg, now we're finally back to our gastrocnemius. The gastrocnemius has two heads. It has a medial head and a lateral head. Medial head's on the big toe side, lateral head's on the little toe side. The medial and lateral heads, their origin are the condyles of the femur. The medial head originates on the medial condyle, and the lateral head originates on the lateral condyle. Their insertion is on the calcaneus bone of the foot by way of the Achilles tendon. This is the Achilles tendon right here. So there is the gastrocnemius lateral head, gastrocnemius medial head. They come together and they are attached to the calcaneus by the Achilles tendon. And there's our gastrocnemius muscle, lateral head, medial head, and the Achilles tendon right here. This allows, medial head, lateral head, soleus tucked underneath there, and the Achilles tendon. The gastrocnemius is responsible for plantar flexion. The gastrocnemius, when it contracts, will pull the heel up to point the toes down. It'll pull the heel up, attach to the calcaneus, it will draw the calcaneus up, and the toes will go down. That's called plantar flexion. And that's how we take our step in that position. And then the tibialis anterior contracts and pulls the toes upward, and we dorsiflex the foot, and the heel goes down. And that's the process by walking. We raise our heel, we move our leg, we raise our toes, and our heel goes down, and we have our foot down, and then we start the process all over again. And that's what the gastrocnemius and the Achilles tendon does for us. Plantar flexion and flexing the lower leg. So, but primarily, it's for walking. And again, there's dorsiflexion and plantar flexion. There is the calcaneus right here. Dorsiflexion involves raising the toes, raising the front of the foot. Plantar flexion is raising the heel and pointing the toes down. All we have left now is to look at the muscles of the torso and the head. And so we have, 1 second. So, muscles of the torso, as well as the head and neck. Okay. So here we have the first muscle nobody ever gets wrong. It's the muscle that's on top of the frontal bone. We call it the frontalis. And it's a very thin, very, very thin muscle, because when you rub your forehead, you can feel the bone, you can feel the frontal bone underneath. So that tells you that that muscle is pretty thin. This is one of those muscles that only has, its only role is to show expression. That's all it does. Our expressiveness shows up by the way that we respond to things. The shape of this muscle is only for demonstrating expression. And it's not the only one like that. This is known as the orbicularis oculi. Oculi means, eyeball. The orbicularis oculi is also a very thin, flat muscle that all it does is show expression. Expressiveness. How do you feel? What are your feelings? And the movement of the muscles around your eye and around the front of your head are going to show that. Another expressive muscle, the orbicularis oris, a circular band of muscle around our mouth. That's all it does. And finally, we have one that does something. This is the sternocleidomastoid. The sternocleidomastoid is that muscle I showed you at the beginning of the class that we use to turn our head to the left or right. This is a working muscle. The other ones are just expressive muscles, but this is a working muscle. We also have the zygomaticus muscle. Again, expression. Doesn't do a whole lot for us for any kind of action. So zygomaticus is characterized by these two bands of muscle that attach here. So it looks like it's in between the orbicularis oris and and it's directly in front of the masseter muscle. I'll show you that in a second too. Okay. So here's a close-up of the face. We have the frontalis muscle. The frontalis muscle is interesting. It actually has two parts to it. It's like, we know that the frontal bone fused from two bones into one. The frontalis formed from two separate muscles. We have the orbicularis oculi, the circular muscle. orbicularis oculi surrounding the eyeball, very thin, flat muscle. The orbicularis oris down here around the mouth. And didn't show you, but it will. There's the zygomaticus muscles right there. There's two little bands of muscles there. So let's go on. Here's the frontalis. See how it's two separate muscles? Yeah. And it's so thin. It doesn't, like I said, it's there for expression. It doesn't do much of anything else for us. And there are the orbicularis oculi and the orbicularis oris. You can see just how thin they really are. All they do is respond to our emotions, happiness, sadness, joy, anger, sorrow, disgust. They get reflected in these facial muscles, as showing our, we are showing our emotions here. Okay. So here's one of the big working muscles of the head. This is the masseter muscle. It's one of the two chewing muscles. When we chew, we have to bring our mandible up against our maxilla. Our maxilla doesn't move. The mandible does. And so we use the masseter muscle to raise our mandible, bring our bottom teeth up against our top teeth to crush, grind, rip, and tear the food that we're eating and prepare it for swallowing. And we start the process of digestion in our mouth by the ripping and tearing of food. There's the masseter. There is the zygomaticus. Right there.
Hey, sorry, you called me. I was calling you back, and Lisa already talked to you.
Okay, yeah, that's fine.
And she's lost too. So we're just trying to find our way around.
Y'all are lost?
Well, we was trying to get off the interstate a minute ago, but we're cool.
Oh, so y'all are back on with us?
No,
We're right behind you.
Oh, okay. Do you need to get off?
No. We're
I
good.
just,
There we go. Okay, sorry about that. Let's get back to this. Okay, zygomaticus and masseter. As I said, the masseter is one of the big chewing muscles. Now this is the sternocleidomastoid. Its origin is on the sternum and on the clavicle. Its insertion is on the mastoid process up behind the ear. You can feel that bump behind your ear. When the sternocleidomastoid contracts, it pulls our head in the direction of whichever side is contracting. If the right side is contracting, our head is pulled in that direction. If the left side is contracting, it's pulled in that direction. The origin is on the sternum and clavicle. The insertion is on the mastoid process. It's a very large and powerful muscle. So there is our sternocleidomastoid right there. It has two heads, two origins, one on each, it has the sternum and the clavicle, inserts on the mastoid, and if both muscles contract, the head flexes, so it bobs up and down. If one contracts, the head rotates in the direction of the contraction, like this. You can see, when we contract, the head turns. So we turn either direction. And if both muscles contract, the head flexes and it bobs up and down, like this. And sometimes we have extreme rotation, which doesn't really happen, but Okay, so I have bizarre taste in movies. So anyway, now let's take a look at some other muscles here. This is the other chewing muscle, the temporalis muscle, located on the temporal bone. Its origin is the temporal bone. It inserts on the mandible. The masseter inserts on the mandible. Both of them are designed to raise the mandible up against the maxilla. As there's the masseter, The masseter is found right in front of this big salivary gland here. There's our ear. There's the salivary gland. The masseter is right in front of the salivary gland. The temporalis is directly above the ear, right here. And there they are. There's the temporalis, and there's the masseter. Both of these are designed to elevate the mandible, to bring the mandible up against the teeth of the maxilla. So the masseter originates on the zygomatic arch. You can see where it originates here. It inserts on the mandible, and it elevates the mandible so we can chew. The temporalis originates on the temporal bone. It inserts also on the masseter and elevates the mandible. And the two of those together give you this kind of action, pulling the mandible up against the teeth of the mandible against the teeth of the maxilla, because the maxilla doesn't move. And the teeth don't move in their sockets, but you have to bring the teeth, the mandibular teeth, up against the maxillary teeth. And it looks something like this. Notice that the maxilla doesn't move. Maxilla is part of the skull. The mandible does move, thanks to the actions of the temporalis and the masseter muscle. So moving on, we're almost done with this. We've only got everything done. Almost there. Large muscle of the shoulder above the deltoid is the trapezius. The trapezius is responsible for elevating the head or elevating the shoulders. We use the trapezius when we shrug our shoulders or we raise our head up to look around. We use the trapezius when we tilt our head over one side or to the other, lay our head over on the side. So we're using the trapezius for that. It's a very large, powerful muscle on our back. Here we have the pectoralis major, large muscle on the anterior surface of the thoracic cavity. If there's a major, there is a minor. The minor, the direction of the muscle fibers, if they're a major and a minor that overlap, the muscle fibers of the major run one way, and the muscle fibers of the minor tend to run in another way. We have greater strength and support with that. So pectoralis major, large muscles in the front of the thoracic, on the outside of the thoracic cavity. And we can't talk about muscles unless we mention the diaphragm. The diaphragm is a large muscle. Diaphragm divides the abdominal cavity from the thoracic cavity. But it's also a muscle. It's a large muscle shaped like a parachute. And when it contracts, it increases the size of the thoracic cavity so the lungs can expand. There's the diaphragm right there. Now the pectoralis major, it originates on the clavicle and the sternum. It inserts on the greater tubercle of the humerus. We can use it to flex the arm, adduct the arm, and rotate the arm. So what does that mean? It means that when we do push-ups, when we throw things, when we're climbing a ladder, we're using our pectoralis major. So a lot of activities involve the pectoralis major. So very large, powerful muscle here. There's the pectoralis major in action. We see different things happening here. It's not just confined to raising your arm out to the side. You do an awful lot with the pectoralis major. The trapezius, the large muscle of the upper neck, upper back, it is causes us to raise our head, to move our scapula. The trapezius allows us to, besides elevating our head, allows us to turn our head, to lay our head over from one side to another. Shrug our shoulders, elevate our head, raise our head up, we're looking around for somebody, or tilt our head over to one side to another, or flex our head back. We can tilt it, with the action of the sternocleidomastoid, we tend to nod our head up and down in the front, but with the trapezius, we can flex our head backwards. Large muscle of the lower back is the latissimus dorsi. This is the muscle that we use to drive a nail or to chop wood. Large overhand motions, large underhand motions too. Throwing things. I always think of fast pitch softball. An underhanded throw, as opposed to overhand, like you see in baseball. But an underhand throw, very powerful, very fast, with the force of the latissimus dorsi behind it. It is the nail pounding muscle, if you will. Let's see, on our model, it's this large muscle back here that extends all the way down to here. And that's the one frequently where your patients will come in on a Monday morning after a very strenuous weekend doing whatever, and they'll say that they think their kidneys hurt or they've damaged their kidneys because they say they have pain in their lower back right above their waistline. Well, and they're holding their back. Well, that's not where the kidneys are. The kidneys are right up underneath the ribs. More than likely, pain in that region, if it isn't a kidney stone, it is likely going to be latissimus dorsi. Yes, that's a very good point. The pushing effect that you can get, the thrust that you have comes from the latissimus dorsi. We see it in various types of sport activities, but pushing again, because there's not a lot of difference between the force you apply to with your arms to push something than what you're using to drive a nail with a hammer, for example. Or throwing a ball overhand or underhand. You're transferring force from that muscle in a forward direction. So yes, that's exactly where it comes from. So, and we injure our latissimus, we make them sore. We strain them doing things, you pick up something heavier than you should, and it's not out of the realm of possibility that muscle's sore, and lots of people think that they're having kidney problems when they really just injured their muscle. But then again, to be perfectly fair, sometimes a sore lower back is a kidney problem. So you can't just say, here, take some Tylenol and go home and don't bother me. You never say that. But you would, you can't just assume because it's lower back pain, it's a strain of the latissimus dorsi, because sometimes it might be a kidney problem. So, I don't want to sound wishy-washy, but human body is funny. Human body does strange things. We have pain in the wrong locations for injuries and disease. Sometimes we show pain and where we shouldn't have pain. Sometimes we actually show pain where it's supposed to be, and sometimes we have no pain at all. So there's a latissimus dorsi. And again, we are, one of our actions, look how it inserts itself on the humerus, and all that force from the latissimus dorsi can be transferred to that humerus for any kind of forward type action. So it's pretty amazing. Other muscles here, serratus anterior, series of muscles along the side of the thoracic cavity, extends down to just below the level of the diaphragm. You also see just the faintest hint of the pectoralis minor underneath here, because there's the major there. Now, the rectus abdominis is an interesting set of muscles that we use all the time, and we don't even think about it. It's often called the six-pack. It extends from the sternum from the xiphoid process of the sternum all the way to the inguinal region. And we use this muscle when we exert force to pick something up. When we're going to pick up something heavy, the rectus abdominis contracts to stabilize the abdomen. It causes the abdomen to flex. Notice how the abdomen compresses. You know, it's flexing. We're not bending over, but we're compressing the abdomen. So the abdomen is flexing here. This stabilizes the abdomen. So we go to pick up something very heavy. You know, we have all of our, you know, we have a lot of force behind it. The problem with this is if you go to pick up something very heavy and you flex your abdomen, you tend to hold your breath, because by doing this, you know, compressing the abdomen like this, the diaphragm can't drop down like it did before, because the diaphragm's right here underneath the xiphoid process too. The diaphragm can't drop down because the rectus abdominis is compressed and is flexed and in the way. So we tend, when we're picking up something very heavy, we're not usually aware of it, but we do hold our breath. Okay. If you've ever picked up something extraordinarily heavy with other people, maybe you're moving something very, very large, and it takes all your strength to move it, you may have noticed at some point that you got a little dizzy, or you maybe even noticed, even more so, that your field of vision began to narrow a little bit, in addition to getting dizzy, and that was caused by holding your breath to do something. This, you know, when we compress the abdomen, we end up holding our breath for a short period of time. Now, this generally doesn't become a problem for us because we pick up something heavy, we put it back down when we're done, we move it. You know, we compress the abdomen when we strain. You know, when someone is straining to do something, you know, even when you're trying to open a jar of mayonnaise, it doesn't want to open. You know, open this jar for me. Okay, you have to twist and twist and twist, and it finally opens. You know, or a jar of whatever. Yeah, it's reluctant to let go, and so you strain to open that. And when you're straining, you're compressing your abdomen. You're flexing. The abdomen is being flexed. It's being compressed. And for a few seconds there, you hold your breath. Now, for most of us, this doesn't cause a problem. But for some people, it does. Because when you flex your abdomen like this, you raise the pressure inside the abdominal cavity. Raising the pressure inside the abdominal cavity stimulates a nerve called the vagus nerve, which innervates our heart. And the vagus nerve releases what we call a neurotransmitter called acetylcholine. Acetylcholine, you're going to hear all about this later on in muscles. Acetylcholine causes the heart to slow down. So now you have, so you're not pumping blood, you know, if you're straining hard, you're not pumping blood as fast as you did before, and you're not breathing, which explains why you get dizzy, or maybe even see, you know, a little fuzziness or darkness at the edge of your vision, because the increased pressure in the abdomen causes the heart to slow down, thanks to stimulating the vagus nerve. And of course, you're not taking a breath either. Now, who really can get in trouble with this are heart patients. Because one of the things we see with heart patients is that heart patients may get, you know, develop constipation from pain medications. Morphine-based pain medications cause constipation. And constipation means they don't get their bowels to move. And because, you know, I suspect it has to do with you know, numbing of nerve endings or something like that. But it may even have something to do with as simple as causing removal of water from the feces, because constipation is really based on water. The more water you take out of fecal matter, the drier it gets. The drier it gets, the harder it is for it to move through the large intestine. So, but regardless of that, people that take pain medication that are morphine-based, even Percocet or Tylenol 3 or something like that, will frequently become constipated. Now, you have your cardiac patient who is trying to empty their bowels, and they forget that they're not supposed to strain. Because straining stimulates the vagus nerve. If they strain, they stimulate the vagus nerve, and they slow down their heart, and it may have bad consequences. So something that you pay close attention to with your cardiac patients. It's often said that Elvis expired on the toilet at Graceland back in the 70s. You know, that because Elvis, you know, liked to indulge in recreational pharmaceuticals, many of which may have been morphine-based, possibly, and slowed down his colon. And so there he is on the toilet, trying to empty his bowels, straining as hard as he can, and he constipated because of the various chemicals he was taking. And he was, of course, not in the best of shape at that point in his life, and strained himself into a fatal heart attack. That's one of the more intriguing theories about how Elvis died. Now, we know Elvis isn't really dead. He's just working at the Shell station in Newport, but that's beside the point. So anyway, so the reason, so, you know, this is a long, involved discussion here in the six-pack, but it has some immense physiological applications here, particularly in dealing with your cardiac patients. So, anyway, so let's move on. External obliques, these are going to compress the abdomen from the side. So when you're flexing, you're probably also compressing it to the side of it too. You want to know where your external obliques are, stick your hands in your pocket and point your fingertips towards the midline of your body. And now you're sitting on top of, your hands are sitting on top of the external obliques. The internal obliques are directly underneath them, but their muscle fibers are running in the opposite direction. Again, compressing the abdomen is the role of the external obliques. Here we see, again, the serratus anterior, the external intercostal muscles. The intercostal muscles are the muscles between the ribs. When you eat ribs, that's what you're eating, intercostal muscles. There's the rectus abdominis again, and the external obliques. Now, the external intercostals and the internal intercostals, their muscle fibers run in opposite directions. The external intercostals, their muscle fibers run towards the sternum. The internal intercostals, muscle fibers run away from the sternum. Here we see on the underside, the internal intercostals. They also have different actions too. There's our internal oblique. You can see it at one line of red there is all we get to see. Transverse abdominis is this entire muscle across here. And there is our diaphragm. Now remember, the diaphragm is shaped like a parachute. It's not just this little thin line. So there's the external intercostals. There's the sternum there, and the fibers that make up the muscles. The muscle fibers run towards the midline of the body. The internal intercostals, the muscle fibers run opposite direction, away from the midline. The external intercostals are designed to elevate the ribs. So they, when the external intercostals contract, the ribs rise up. The lungs are attached to the inside of the chest wall. When the ribs rise, the chest wall rises. The ribs expand because the chest wall is increasing in size. At the same time, the diaphragm contracts and moves down. So now the thoracic cavity has enlarged its space. The air pressure inside the lungs drops and air rushes in. When we want to get that air back out, the internal intercostals compress the ribs. When they contract, the ribs relax and contract. The ribs drop down. The muscles pull the ribs down. the diaphragm rises up, the thoracic cavity shrinks in size, and air is pushed out. That's the whole process of breathing. Here's our diaphragm, shaped like a parachute. The diaphragm can be found right behind the xiphoid process. It's all around here, and it tucks in there with the rectus abdominis muscles. And you can see if they're flexed, then the diaphragm isn't going to have a lot of effect in contracting. We see that the diaphragm and the intercostal muscles work together. Notice how when the ribs rise, the diaphragm drops. When the diaphragm is dropping, it's because it's contracting. There goes the diaphragm contracting. When it relaxes, it expands. When the ribs rise, the diaphragm is going to drop. There go the ribs, and the diaphragm goes down. The thoracic cavity enlarges. So, and that lowers the air pressure inside the lungs because the lungs have suddenly gotten bigger and air can rush in. And that is everything on muscles. Any questions on this? Okay, then I'm going to get us out of here. Y'all have a good weekend. And I will post this video as soon as I get it processed. Thanks a lot and see you later.